And thank you for being here. Welcome to my dining room. No, fortunately, you can't see it. But I really do want to thank everybody for being here. I know that we are confronting some trying times, dealing with the COVID-19 epidemic, and really making a stand against police brutality and social injustice. So I thank you all for being here today. And what I'm going to present is a cisgender women and PrEP pilot research study that we conducted at the University of Pennsylvania School of Nursing and at the Project Achieve at the New York Blood Center. And Dr. Ann Titleman was the principal investigator here at the university site, and Dr. Han Van To was the principal investigator at the Project Achieve site, and I was the project director. So my slides are not advancing. Kyle?
Annette, maybe just click on this. What are you clicking at the moment?
Well, there you go. All right, I see how you do it. Okay, thank you. So this is actually, I wanted to acknowledge and give some thank yous to our community consulting group members and our community partners, and a special thank you to the participants who were amazing women who really shared lots of their personal experiences and personal encounters with us. And I always applaud them for being so candid and open. And of course, thank you to our research staff and our students. And so here's some background. So as we know, HIV is disproportionately affects economically disadvantaged and minority women. And it was really alarming that currently for us to realize that there was not a proven effective behavioral intervention to promote PrEP uptake for cisgender women at a risk of exposure to HIV. And so as we, to continue to, for PrEP to be continually underutilized among cisgender women, we know that this underutilization leads to inequalities in HIV infection and increased morbidity and mortality among poor women. So here in the United States, we really know that we needed an effective approach to support PrEP use for cisgender women. And so here were the objectives of our study. The study was to develop and evaluate an intervention to promote PrEP initiation among cisgender women in partnership with our community consulting group. And the study was conducted, as I said earlier, in Philadelphia and New York City. And the reason we really appreciated our colleagues partnering with us in New York is because the cities between New York and Philadelphia had significantly different landscapes in terms of PrEP access. New York, as you might know, had a very robust campaign that had targeted ads and messaging for men who have sex with men, transgender women, and cisgender women in terms of PrEP access, information about PrEP, and where you could access PrEP for PrEP assessments. And in Philadelphia, it was just getting started that there were beginning to have messages and campaigns for PrEP uptake, and they were focused mostly at that time on men who have sex with men and transgender women. Transgender women. So we really wanted to see if the landscape within the cities also made a difference. The intervention was theory-based and contextually relevant behavioral intervention. It was combined with linkage to healthcare and social services. And we also had a text messaging support for adherence to PrEP component in the randomized clinical intervention. So let me share with you a little bit about how our community consulting group evolved. Initially, the CCG was comprised of women who primarily worked in organizations and agencies that offered services for women who might be potentially eligible for the study. But as we were out in the field and we were recruiting and we were talking with women about the study, and even initially when we conducted the in-depth interviews, which I'll talk about in a little bit, we really wanted to have women's voices on our CCG. So we invited some of the women who were interested, and that, as I mentioned, that to us was exceptionally important to have a kind of a balanced voice of providers or people who were providing services and actual women's voices who were women who would have been potentially eligible for our study. And the community consulting groups happened both in New York and in Philadelphia. So each of the research sites had their own community consulting groups. But when we met with each of our groups several times during the course of the different phases of the study, where we would share findings and provide interpretations and had very rich discussions. And we also wanted to name the study. And we thought the best group to name the study would be the community consulting groups. So both groups brainstormed possible names, and then they voted on the name and came up with Just4Us. I'm sorry that this slide is a little off kilter, but this was our logo for the Just4Us. And so anyway, so here, as I was saying, the research study had 3 phases. The first phase was in-depth interviews where we enrolled 41 women. The second phase was a survey where we enrolled 160 women. And the randomized clinical trial, or the intervention aspect of the third phase of the study, enrolled 38 women. And these are, they were 50% of the women were enrolled in Philadelphia and 50% of the women were enrolled in New York. All the women enrolled in any of the phases of the study needed to be eligible for PrEP, and they needed to be within the ages of 18 and 55. So for the in-depth interview, there was a one-to-one interview guiding participants through a conversation about ways participants or ways women kept themselves healthy, things that she was doing to prevent HIV. We provided information about PrEP during the in-depth interviews. We engaged in conversation and exchange of ideas, of thoughts about starting PrEP. What would be a woman's facilitator or barriers? We had scenarios that our CCG helped us design that were realistic situations for women to talk about what the women would do in these situations, how they would initiate PrEP, what would be barriers. And some of the scenarios that we engaged in conversation with the women were if you had just ended a relationship and wanted to start dating again, and during your dating, you might want to have sex with a partner, and what did they think about having PrEP on board for that? A few of the other scenarios were a woman in a relationship recently learning that her partner was injecting drugs. And then another scenario was a woman finding out that her husband was also engaging in sex with other women. And so our CCG really helped us with those scenarios, so they were realistic and and also helped us with the terminology and language to use during presenting the scenarios, because we wanted them to be as respectful to women in their real life situations as possible. And for the survey, they were red cap surveys or CASI surveys, where women would read the questions on a computer or an iPad and directly enter their responses into the computer. And that actually ensures an increase of confidentiality. And then the third phase, as I said, was the randomized clinical intervention. So what was the eligibility crisis? The broad brush of eligibility for the women were to be eligible for enrollment in any of the phases of the study. As I said earlier, that they needed to be between the ages of 18 and 55. Everybody needed to be HIV negative, currently not on PrEP. They needed to be able to read and understand English at a 5th grade level. They could currently not be pregnant, and they needed to fit into the eligibility criteria that I'm going to review with you in the next slide. For the randomized clinical intervention, we also, because we had a text messaging component, women needed to have a cell phone or a device where they could receive text messages. So I know that this is a kind of a busy slide, so I'm gonna walk you through it. When we would screen women for eligibility, they needed to report that they had engaged in condomless vaginal or anal sex with a cisgender male partner in the past 3 months, or injected drugs in the past 3 months. So those were sort of the baseline criteria that women had to meet for eligibility for enrollment. And then they had to report either one of these other risk behaviors or risk situations. So they either needed to have a current male partner who was injecting drugs or was having sex with men, a male partner who is HIV infected, a current male partner who had been incarcerated in the last 6 months. They themselves could report that they had been sharing injection drug equipment in the last 6 months, that they were in a methadone, buprenorphine, or Suboxone treatment program in the last 6 months, that they engaged in sex for money, drugs, or goods or services in the last 6 months, or they were using cocaine, powdered cocaine or crack cocaine at least more than one time per week in the last 6 months, had a new infection or new diagnosis of chlamydia, syphilis, or gonorrhea, and alcohol abuse in the last 6 months, assessed through the CAGE with a 2 or higher score, or that they had more than 3 sex partners in the last 3 months. So those were the criteria that women who were enrolled in any of the phases of the study needed to meet in order to be eligible for enrollment. So where did we find the women? Where did we go for recruitment? Both in New York and Philadelphia, we recruited women at women's shelters, advertised on Craigslist, recruited at independent residential recovery houses, methadone clinics, and we implemented a snowball recruitment strategy for women interested in assisting us with referring their network of friends to the study. So let me walk you through how we conducted recruitment. Our recruiters had flyers, and whether it was in street outreach or at a methadone program, we would approach women, we would show them the flyers, we would say we're from the University of Pennsylvania School of Nursing, we're conducting a research study, the women would see the flyer, see some of the salient inclusion criteria like age and a bit of what the study was about. And then we say, are you interested in learning more about the study? If women said that they were interested in learning more about the study, then we would go to a quiet area. If it was outside, if it was in one of the residential programs, many times they would offer us a private confidential office where we could meet with women. We would give them more information about the study, and depending on the phase of the study, if it was the in-depth interview, we would tell them a little bit of how that was going to be conducted. If it was for the survey, we would share with them that it was, completing a survey on a computer. And if it was for the randomized clinical trial, we would explain what that was about. And if they were interested, then we would administer the recruitment questionnaire. And those were the questions that you saw on the previous slide that they needed to, affirm that they would be eligible for. And when we could administer the eligibility questionnaire on an iPad, we gave the women the iPad so they could read the questions themselves, enter their responses, and then when they hit submit, the iPad would show whether they were eligible or ineligible. So we try to keep as much of the personal, risk behavior as confidential as possible during the recruitment efforts. And for women who were eligible and wanted to enroll in the study, we could then schedule their in-office study visit right there. A little bit about the snowball recruitment. For women who were actually enrolled in the study, they could receive up to 3 coupons, and they would then take those coupons and give them to a woman in their social network or somebody who they thought would be interested and potentially eligible for the study. And if their network members enrolled in the study, the index participant would receive $10 for each of their network members who were enrolled in the study, up to a maximum of $30, because they only had the option of 3 referrals. And this proved to be a very helpful recruitment strategy. It yielded a number of women enrolling in the study who we might not have encountered in our usual recruitment efforts. So what were some of the key findings from the in-depth interview? So women revealed that they really needed more information about PrEP so they could decide if PrEP was a good option for them. And women were really surprised to learn about PrEP. So many of the women had never heard of it. And those who had heard of it said that they thought it was only for men who had sex with men or people who were injecting drugs. They also said that when sharing information about PrEP, it's important to frame the conversation that provides tools that make information easy for women to make a decision about PrEP uptake. For conditional acceptance, women determined that it was really needed, that PrEP was a needed option, but that they needed to also have the option to take PrEP that would fit into their lifestyle. Public service campaigns, women thought that there needed to be ads that were relevant to them, and that really, the images, the messages needed to speak to them specifically as women, as cisgender women. And stigma, if many of you might remember when PrEP was first rolled out, there were, you know, and we heard a lot with men who have sex with men being called PrEP whores and being accused of promiscuity. Well, women were also concerned about the stigma if they decided to take PrEP. They were concerned that people would perceive that they were HIV positive or that they were sexually promiscuous or being unfaithful to their partner. And then the women who also were grappling with substance use recovery or maybe even continuing in their substance use felt that there was like a double stigmatization of being, quote, seen as a drug user as well as now somebody using PrEP. We also realized that we needed to really work through the issues of structural barriers. Women brought up issues of housing, of jobs, mental health. Many of the women talked about dealing with depression and anxiety. And so you need to, what they said is who's ever working with them to take PrEP would really need to help them work through these structural issues before they could make a determination about if PrEP was a viable prevention option for them. And of course, social supports are always needed. You know, it's useful to know who is going to support you with your decision of PrEP uptake. So what did we use to design the Just4Us intervention? And now we're moving into the randomized clinical intervention. And so our research team conducted extensive literature searches, including reviewing publications on PrEP uptake and HIV prevention behavioral intervention designs, looking at literature for men who have sex with men, transgender women, discordant couples literature and research. And as I said earlier, there was nothing on a behavioral, theory-based behavioral intervention for cisgender women and PrEP uptake. And though our team also came with extensive experiencing authoring in-depth interview guides, conducting in-depth interviews ourselves, designing surveys, and theory-based HIV prevention interventions. And also the information shared during the in-depth interviews and the responses from the survey helped us design what needed to be the content in the randomized clinical intervention. So we knew that women's voices were really being heard as we began to design the intervention. And the CCG was also really helpful because we piloted the interventions with them, the activities, the language, to ensure that it was respectful and sensitive to women who would be enrolling in the study. They also, and I'm going to talk about this in a little bit as well, but the CCG also, we wanted to provide information about PrEP for all the women who were enrolled in the randomized clinical intervention so they could take it away with them and continue to have a resource. And what the CCG explained to us that we really couldn't just have, distributed PrEP information because some of the women might be going to, home where there might be intimate partner abuse, or their partner might question, well, why are you bringing home this information about PrEP? So what we developed or designed in our handouts, what we called decoy handouts. So we included in these handouts, sort of how to stay healthy. We had a handout on nutrition, a handout on smoking cessation, a handout on exercising, and handouts on PrEP. So then women could say, well, I was at a health conference and I just picked up this material and this information. And actually some of the women who were staying in residential residential treatment programs also said, they didn't want other women in the residential programs to know their business. So, so it was really helpful to be sensitive and recognize the need to offer this decoy handout. So the Just4Us randomized clinical or controlled intervention, here we actually, we assessed for eligibility 255 women and enrolled 83 women. And these were cumulative numbers on both, at both the New York and Philadelphia site. The randomized clinical trial, the process was that women would come into the study sites for their baseline appointment or baseline study visit. They would go through an informed consent process. If they agree, so that way they would learn, know exactly what was going to be asked of them, what kind of questions we were going to ask, the possibility of being in the intervention arm or the control arm. And then if they agreed to enroll in the study because all of their questions had been answered, then we showed them a video. It's a high video. If any of you are interested in looking at it, it's a great 3-minute video that really succinctly talks about what PrEP is, and that, we're talking about Truvada when we talk about PrEP, both for this study and in this video. It's geared to women. It's why women should perhaps consider PrEP uptake. And so you can Google it. It's a great video. And we knew that we needed to give women a baseline information about PrEP because, as we learned, women prior to this study, many of them hadn't heard of PrEP, and because the next procedure was going to be completing a survey, they needed to have some information about PrEP. And so after they saw the video, they completed the CASI survey that I earlier explained. And then everybody in the randomized clinical intervention was actually tested for HIV. Because it was research, we couldn't just rely on self-report. We really needed to have a negative HIV result. And we used a Generation 4 device for the testing. And once it was confirmed that the woman was HIV negative, then they were randomized into the control group or the intervention group. And all women, regardless of what group they were or what arm in the study they were randomized to, everybody came back for a 3-month follow-up visit. And those of you who are familiar with research, you know that the success of a research project is to enroll the number of people who you say you're going to enroll and retain at least 90% of the people to come back for a follow-up visit. And our overall retention rate was 90%, which is actually what the gold standard is. So we're really very proud of that. So what was the Just4Us intervention? By the way, regardless of what arm you were in, all participants met with a counselor navigator. The counselor navigators conducted for the Just4Us intervention a 1-hour counseling session that had 12 mini modules. And the modules went from information about PrEP, beliefs about PrEP, including stigma, perceived susceptibility. So we had, we walked women through their own perception of their HIV susceptibility, possible exposure to HIV. Talking about, how to talk to others about PrEP, how to talk to your provider, how to talk to friends, how to access PrEP, the barriers. We walked through barriers and solutions. And then we also had an initiative of a text messaging to remind women about appointments and to take PrEP. And then there were follow-up phone calls to help women work through any of the barriers. As I mentioned, the control arm received information handouts. The counselor navigators worked with, reviewed the handouts with the women, and all the women received a tote bag with the Just4Us logo on it, and all of the decoy handouts, as well as condoms and lube. Excuse me. So the Just4Us intervention had empowering themes, and I'm going to talk a bit about the intervention arm. So the modules were designed to walk women through the process that promotes information, or promoted an informed decision-making process based on the women's life situations. So even though, as you see here, they were empowering themes, they were all, and there were, the modules were, there were standard modules, but they were designed to be individually tailored based on the women's situation, personal experiences, and what she was encountering. And it was through activities like role playing, conversations. We had on an iPad, they were interactive activities. So on an iPad, we had what we called a roadmap, where the women, we had put certain barriers that women might encounter on the roadmap, like jobs, childcare, finances, transportation, any of the possible barriers that might affect their ability to schedule a PrEP assessment with a provider, get the prescription filled, and initiate PrEP uptake. And all of the role plays activities were really designed with a harm reduction approach. So it was always meeting the women where they were at, listening to their voices, and incorporating what they would share, their experiences, their realities into the activities. So as I was saying, they were active learning strategies. There was a teach back where they practiced how to talk with their provider about why they were interested in PrEP uptake, how to talk with their partner about why they might consider starting PrEP, how to talk with families and friends. And then the text messaging was a self-creative text messaging process. So who were the women who we enrolled in this study? The average age was 38 years, 26% identified as Hispanic, 79 presented or identified as Black or African American, 28% had less than a high school education, 71% reported $12,000 income in the past, less than $12,000 income in the past year. 82 reported that they did not have enough money in the household for rent, food, or utilities in the past 3 months. 60% had ever been in jail or prison. 49% spent 1 day or more in a shelter or an emergency living situation. 89% had health insurance. Then we had a section in the survey where they talked about their own substance use. So in the past 3 months, 38% had 3 or more alcoholic drinks per day. 46% had 6 or more drinks of alcohol when they drank. 11% reported using heroin in the past 3 months. 19% used other opiates like Oxycontin or Percocet. 13% of the women were injecting drugs, and 40% were in a drug treatment program in the last 3 months. In the section where they reported on their male sexual partner and their chances of exposure to HIV in the past 3 months, they reported that 20% of their partners were injecting drugs to get high. 41% of their partners had sex with someone else. 27% of their partners had were having sex with other persons for money, drugs, or services. And 4% had HIV. And 36% of their partners had spent time in jail or prison. And 27% were having sex with men. Now, for the women's behavior and their chance of exposure to HIV based on what was happening in their lives, 74% had 1 or more sex partners in the past 3 months. 90% had inconsistent condom use in the past 3 months. 75% of the women used condoms the last time that they had vaginal sex. 68% used drugs or alcohol to get high or drunk before having vaginal or anal sex in the past 3 months. 47% had sex with a man for money, drugs, or services in the past 3 months. Their own perception of their own susceptibility for HIV, 51% believed that they were currently at risk of getting HIV, and 56% believed that in the past 3 months that they had been at risk for getting HIV. Now, just remember for a minute, remember I said that all the women who were enrolled in the study either hadn't heard of PrEP or thought it wasn't for cisgender women. And none of them were on PrEP. And yet, here we have 56% of the women self-reporting that they believe that they were at possible risk for exposure to HIV in the last 3 months. And hopefully we can get back to that during the discussion and the question period. So again, more description of the participants. So their relationship with their healthcare providers. 90% of the women felt that they could be open about their sexual behavior with their health provider without being judged. And 90% of the women felt that they could talk and share with their health provider about their drug use and not be judged. And 95% of the women felt that they were respected by their health provider. So going back to what I was just pointing out to you, here are women who felt that they could talk about their sexual practices with their health provider, talk about their drug use with their health provider, that they felt that they were at possible risk of exposure to HIV, and yet none of them were on PrEP, and most of them had never heard of it. I mean, that to me is astounding. And so we need to really think about this, and so we can talk about this hopefully during the the discussion period. So here were the section where we asked about if starting PrEP in the next 6 months. So 69% would prefer to go to their own provider if they wanted to start PrEP in the next 6 months. 18% said that they would prefer to go to another provider, not their primary care provider. And 13% of the women just weren't too sure if it really mattered to them. They really needed to think about it. As far as the PrEP-related questions that we had, 53% had not heard about PrEP prior to the study. As I mentioned, none of the women were on PrEP. And when we asked about the first choice to prevent you from getting HIV, 40% said male condoms, 13% said PrEP, 12% said not having sex would be, a choice, a first choice. And 9% thought that if they knew their sex partner's HIV status, that would be a priority. And 79% of the women plan to take PrEP in the next 3 months. So we also conducted, and let me just mention that all of the surveys and all of the questionnaires were on iPads or on computers. So women could answer their responses without knowing that the research assistant that was conducting their study could see their responses. And so we asked all of the women who were enrolled in the intervention arm of the study, their satisfaction about the intervention. So the overall satisfaction rate, 95% of the women were really satisfied with the overall Just4Us intervention. The discussion, the activities, and the role playing, 95% of the women were reported being satisfied. With the video, I think I forgot to mention also a video that we showed. We showed the HIDE video, but we also showed for the intervention arm of the study, a video that had been designed by a colleague in New York for another research project that she was conducting. And it was a sort of an animated video with women having a conversation amongst themselves about PrEP, why they should take PrEP, that it's all about them, PrEP is like just for us conversation. And then at the end of the video, there were health providers talking about who would be eligible for PrEP and who, And so we showed this video. So 88% of the women thought the video was satisfactory, and the duration or the length of the intervention, remember, it was geared for an hour one-to-one with a counselor navigator intervention, and 70% of the people, women, thought that was a satisfactory time. And the text messaging, there were 92% of the women who were satisfied with the text messaging. And what I think I also neglected to mention when I was describing how the text messaging was individualized for the women, we had initial text messages to remind women about keeping their PrEP appointments, getting their prescription filled, but then the text messages that would remind women to take a pill every day, those messages were designed by the women themselves of what the message that they wanted to have sent to them. Because we surely didn't want to send messages like, did you take PrEP, or, did you take your medication? And they came up with messaging like, they wanted the message to be sent, did you love yourself today? And then they would respond back, I loved myself today. One woman said she wanted her message to be, were you a princess today? And then her response would be, I was a princess today. And another woman that I can remember came up with, did you love, and she wanted to use her daughter's name. And so the message would come back is, I loved, Dara. And so it was, they really appreciated that they could design their own messages that were self-affirming for them. So it was their voice, their message, what was important for them to know that they were taking care of themselves. And here are some of the comments that participants shared with us. So one of the participants from New York said, it was helpful, informative, and a good knowledgeable way to educate the public about PrEP. Another New York participant said she learned a lot from the intervention, such as how to speak to others about PrEP and how it can protect you from HIV. And then one of our Philadelphia participants said telling friends about PrEP was one way she could help when she didn't know how to change their lifestyle, like shooting up drugs. The list of questions, frequently asked questions about PrEP, and other information she received in the packet had helped her with talking to her provider and others about PrEP. So that is the presentation. This was our flyer that we distributed. And I thank you all for being here this afternoon. And also, just so you know, we are presenting at the International AIDS Society, even though it's virtually presentations. And so some of the statistics that I wasn't able to share with you today is because there was, what they call an embargo, that you're not allowed to share information until it's presented. So if any of you are interested, come the fall, for me to come back to actually present a more robust statistics and what we learned from this research project, I'd be more than happy to do that. I don't have my email on the slide, unfortunately. And I know that Kyle, though, I think that you can perhaps get that to everybody who might be interested if they send that in the chat box, or if you can send their contact information to me, I can send my contact information to them. How do I now turn on my, oh, I see, I know how to do it. There you go.
Wonderful.
Thank you all. So this is who I am.
Thank you. And to the audience, this is your time to put on your thinking caps and think about some really great questions you may have for Annette. So we budgeted out this time so you all can, we all can have a conversation about this. First of all, I want to thank you, Annette, for presenting this. I was really taken by the fact that there was a 90% retention rate, which is phenomenal. You know, that's a really great number at the end of the day. So congratulations on that. And also, I just want to make a note. I remember when PrEP first came out, right? And I do remember a lot of the conversations that were going around that were specifically sex shamey. I remember the Truvada whore, incident very vividly. I just wanted to ask you, and while folks are thinking about their own questions, I just wanted to ask, what shifts in attitudes towards PrEP have you seen on a macro level, just from the beginning of the PrEP coming on the scene to now, and also the shifts in attitudes in the study? Did you see a shift from the start of the study to the end of the study? So it's kind of like a two-part question.
So that's a really good question. And what we're realizing is, because it was such a short follow-up period, that many of the women were having a difficult time getting an appointment with their provider in a timely fashion before the follow-up visit was scheduled. We also found that some of the providers didn't know about PrEP or weren't comfortable prescribing it. So they wanted women to they wanted to refer them to another provider. And I'm sharing this because I think that your question leads to the fact that we probably, to be able to statistically answer your question, to have women come back again now for a follow-up appointment, because we don't know how much of a shift, because people were in the transition of, getting an appointment or determining whether PrEP was a viable option for them. Many of the women were also saying, I need to put it off for a bit because I'm still dealing with my recovery process. And I think those are the kinds of situations that we need to realize, that even though we would love to have as many women, initiate PrEP based on their personal situations, there's so many competing issues in women's lives that get in the way. I might have the best intention to have an appointment to get assessed and evaluated for PrEP uptake, but when am I going to schedule this? When am I going to, put this, splice this into my everyday activities when I need to perhaps get my children to daycare or get them off to school, and then maybe get to work and then get back to be home for them, and and then transportation, and can I get to the clinic during clinic hours? And then what we saw, what I thought was so glaring is that women, 50% of the women had never heard of PrEP, and yet they, who did they want to see? The majority of the women wanted to go back to their primary care providers, and yet their primary care providers weren't talking with them about PrEP. And that's not the point of finger, is to say, there's work to be done.
Mm-hmm.
And so I don't know if that answered your question or not. I hope it did.
No, absolutely. That was incredibly helpful. I think I've been speaking ad nauseum to providers this whole conference, saying we need to be better. As service providers, we need to work to, dismantle that gate and that gatekeeping that, I think the social services and the, healthcare world has, put up. So I appreciate that.
Yeah.
So we have a question. They say, thank you for a great presentation. So the question is, knowing the results of this current study, if you could redesign the study, what would you do different, or would you keep it the same?
That is a terrific question. One, I would do a few things, but one I would definitely do is not just have a 3-month follow-up visit. I would have a 3-month follow-up visit, and I would have a 6-month follow-up visit. And so the 3-month follow-up visit, I think, could focus on, the decision-making, whether to initiate PrEP or not to initiate PrEP, and really spend more time focused on the decision-making process, go through what was happening in a woman's life back 3 months after enrollment, after they've received information about PrEP, after they've had perhaps even experience of trying to get on PrEP. I know one woman had an appointment. She waited 4 hours for some reason. She just wasn't being seen, and so she left. And then, so I would definitely have a 3-month follow-up visit and a 6-month follow-up visit, because I think that in between time is where we could really help guide women based on the realities of their lives.
Mm-hmm.
So that's definitely one change I would make in the design
Mm-hmm.
of the study.
Absolutely, yeah. And if I may ask for further clarification, what was the time frame, or is there an embargo on giving us when that study was conducted?
I think I had those dates, because you're asking somebody for dates, but I have let me find it, when we started. Give me a second. I don't want to go back in this. Oh, here.
No worries.
So the randomized clinical intervention started November 2018 and ended in June 2019. And the 3-month follow-up visit, they were conducted during the month, they ended in the month of October. So obviously not everybody came back in October. So that was the year. And if you think about it, so PrEP has been on the market, so to speak, since 2012. And we started the randomized clinical intervention piece in 2018, and cisgender women still hadn't heard of it.
Yeah.
You know, that, and just to add to what you were saying about talking with primary care providers, you know, we learned about this in HIV, you know, that we didn't bring everybody to the table so we could normalize HIV testing. And now we really need to bring everybody to the table to normalize having conversations about sex, sexual practices, and how this entity called PrEP, for women now we're only speaking of Truvada, can be offered as a potential HIV prevention intervention. And so we can learn a lot from what we didn't initially do during the beginnings of the HIV epidemic, when we said only HIV testers and counselors could test for HIV. So I just wanted to add that. Anyway.
Oh, absolutely. And thank you for reiterating the time frame. It provides a lot of context, thinking about it in conjunction with the introduction of PrEP to the work that we are all doing. I think context is important. And I could only imagine, what a study like that right now would be going through, the challenges, thinking about the stay-at-home orders and I've seen a lot of questions proposed, like, what does PrEP adherence look like if you're, socially distancing for, what has it been, 3 months now? So I can only imagine what some studies are experiencing at the moment, or researchers are experiencing at the moment.
And just to add to that, those of us who are PrEP advocates, and I imagine everybody, on this workshop today or is a PrEP advocate, is that there are times when you don't have to take PrEP, and then you can start it again. And we need to educate all people who could benefit from being on PrEP, in a time, in a point of time in their life, and then maybe stop and then can start again when it's relevant. Now, we do know that women need to get PrEP on board, for a longer period of time than men do, but for vaginal sex. But we also don't talk much about women and anal sex, and maybe we, might think about that as well. So I don't know. Anyway, any other?
Yeah, so we have another question. They asked, some women said they were comfortable to discuss PrEP with their doctors, but were not aware of PrEP. How do you reconcile that?
Well, I think that's a great question. Because one is we probably need a more robust campaign that focuses on cisgender women, that addresses, the messaging. I mean, that's what women were telling us. We need more images that we can relate to. We need messages that we can relate to as cisgender women. So the word just isn't out there with a real punch to it. So I think that the PrEP campaigns, that perhaps we need to be certain that they're not like last on the list, so to speak. In the brochures and the campaign, maybe they need a